دكتور معلش عندي سؤال قبل لا نبدأ بخصوص
اتفضل.
الجايد لاين مال نايس. قريب من جينا ولا في اختلافات؟
طيب، بسم الله الرحمن الرحيم. Today inshallah we will continue on respiratory system. We'll do respiratory tract infection and the acute bronchitis, bronchiolitis and pneumonia, bronchiectasis. Okay. طيب, what are the most important يعني في upper respiratory tract infection? It is common in the practice, but in the exam also common, but the questions, the topics which you need to concentrate on the exam is the decision of antibiotic. When to give antibiotic prescription, when to give delayed antibiotic prescription, and when definitely no need for antibiotic. They will concentrate on this because there is a lot of malpractice in prescribing antibiotic, which causing a lot of burden in the international resistance of antibiotics, especially the upper respiratory tract infection. Everywhere, every doctor, every clinic, antibiotic, antibiotic, antibiotic. Okay. What are the upper respiratory tract? Nasal cavity, pharynx, larynx, and sinuses. 90 to 95% of the infection of this part of the respiratory system is a viral. Okay. طيب, سؤال بسيط again, just to understand why all يعني most of the upper respiratory tract infection are viral rather than bacterial. Why?
Virals are easier to spread in droplets.
Yes, because it's easy to spread. Common cold, influenza, COVID, RSV, easy to spread. عشان كده it is common, and because viral easy to spread, that is why it is the most common causes. يعني almost all, نقدر نقول almost all the upper respiratory tract infection are viral. And the upper respiratory tract infection is protected by nature, by defense system, by local normal defense system against bacteria. Okay. Why I'm saying this, I want to assure you not to give antibiotic for upper respiratory tract infection. It is not that common. It is not that easy for bacteria to settle and cause infection in the upper respiratory tract. Why? There is mucus, there is cilia, and there is another very important defense system in the upper respiratory tract. Can someone tell me? Because it is important to know, and it will help us also to decide when bacteria can be suspected. Anyone? Actually, there is two. Other than mucus and cilia, which is protecting against bacteria, طبعا virus have the ability to overcome this defense system. But the bacteria cannot. توحل على طول in the mucous membrane. The mucus can be cleared by cilia before invading. It's not like the virus. And there is also normal bacterial flora in the upper respiratory tract which act against the pathogenic bacteria. Lakin there is another defense mechanism. ها شباب.
هو usually bacteria is easier to actually identify يعني by the macrophages
Yes,
white
yes.
blood.
But I want the mechanism because it will help us to anticipate which patients can get the bacteria. IgA, there is IgA antibodies in the secretory of the upper respiratory tract. عشان كده those who have a deficiency in IgA, they can easily get upper respiratory tract bacterial infection. So mucus, and if there is ciliary problem, patient can easily get, bacterial infection. Like whom patients?
Smokers,
Smokers, تاني ciliary dyskinesias, cystic fibrosis. And they, because they have a defect in the defense system of the upper respiratory tract.
we have Dr. one question that's
Yes?
repeated for the exam. It's about a kid who usually gets sick by upper respiratory tract infections and all. And the diagnosis for the patient is cystic fibrosis. A lot of the,
Yes.
doctors actually get confused. Why cystic fibrosis and they only focus on upper respiratory. Now you explained it.
Yes. Especially children with common variant immunodeficiency because they have deficient in IgA. The patients with immunocompromised have low IgA. Patients with ciliary dyskinesia, Cartaginer syndrome, cystic fibrosis, they have more chance to develop bacterial upper respiratory tract infection. If the patient is healthy, you will not expect, bacterial upper respiratory tract infection. And that is why no need for antibiotic for a healthy patient with upper respiratory tract infection unless there is exceptions. The exam concentrate on these exceptions. And they will ask you when antibiotic may be indicated. And it is indirect question to when bacterial infection can be expected. You got the point now, Jama? Other than that, the bacterial infection usually require trigger. Okay, bye. What are the common causes of طيب نرجع للفيرال common cold, laryngitis, even the bronchitis. I know bronchitis in the lower respiratory tract, down to the bronchi is viral. Common cold, pharyngitis, bronchitis, most of the sore throat, most of the rhinosinusitis, okay? Pertussis, and epiglottitis we need. But the others all are viral. Okay. Is it clear يا جماعة؟
Crystal clear.
Okay. طيب. A common presentation in the scenarios, if they want the diagnosis, well, this is unlikely. Like if the scenario talking about nasal congestion, rhinorrhea, low-grade fever, sneezing, they are talking about the common cold. طيب, if I ask you, and I explained this many times, those who have the course with us the last time, what is the color of the nasal mucosa in common cold? And what is the type of secretions?
Clear or runny?
That is the rhinitis. For common cold, the nasal mucosa will be congested and the mucus secretion will be mucoid because it is viral infection. Viral infection, the body will stimulate the defense system and will produce more mucosa, more mucus. That is why the nasal discharge will be mucoid. And there will be hyperemia because there is inflammation, there is infection. In the infection, there is redness. This is very important to differentiate between rhinitis and common cold in real practice. So as instead of giving treating a patient as a common cold, you can treat it as simply as rhinitis. Rhinitis, the nasal mucosa will be pale, shiny, and the discharge will be clear, watery. That is rhinitis. You can see the water coming from the nose, not mucus. Okay? And if you look at the nasal mucosa, in the nasal septum, in the nasal mucosa itself, you will find it is watery. Okay. If there is viral infection, infection means itis, rhinitis, but viral rhinitis, it will be mucoid, cough, and the nose will be congested. You can see it is congested like a strawberry. Okay? A slight mucopurulent, maybe. Sometimes rusty sputum, maybe. Maybe many of you now, many of you, I am sure there is one or two of you may have now common cold. And one of two of you, if we are 10 here or 15, have rhinitis. You can see that. Just look at your nose in the mirror. You will know what I'm talking about. Okay. So pharyngitis and tonsillitis, there will be sore throat, otodynophagia, fever, and red swollen tonsils. Red swollen tonsils, I'm not talking about pus follicles or pus coat. Red swollen still may be viral. Even tonsils enlarged with red swollen could be viral. Pharynx, just congested like a strawberry. Viral. Just you need to tell the patient that it will take 7 to 10 days. عشان ما يعمل shopping, not to go for shopping here and there. And someone will give him antibiotic on day 7 and he will be okay tomorrow. He will say, oh, that doctor delayed too much. He's not a good doctor. He didn't give me antibiotic. Tell him it will take 7 to 10 days.
Unfortunately, this is always the scenario. They're
That is
always
all.
like, wait 5 days, 6 days, take the antibiotic, and they say, yeah, that doctor is the only one who knew what's going on.
Yes, he didn't give me antibiotic. Okay, and he will put the success on the bad doctor. Okay, right. Sinusitis, still the sinusitis are viral unless more than 10 days symptoms, unless there is high grade fever, severe facial pain. Okay, or I want one of you give me what are the features of bacterial sinusitis. When to suspect, when to give antibiotic for sinusitis. قلنا معظمها most of it is viral. Unless we will suspect bacterial if it is more than 10 days symptoms or very high grade fever, severe facial pain. Huh? I want one of you give me the fourth criteria for suspicious of bacterial that may lead to a decision of giving antibiotic.
Virulent discharge. Virulent discharge.
Virulent discharge, yes, it is a feature of bacterial, but it is not a key feature.
Fever.
If the symptoms improve and then worsening back after improvement, here we will suspect secondary bacterial infection. The first viral improved, then rebound symptoms develop again. Here we can suspect bacteria in sinusitis. Please don't give azithromycin for sinusitis. Wallahi, I am seeing 100 of doctors' prescriptions giving azithromycin to sinusitis, which is a bad practice. And nice guidelines mentioning clearly, don't give routine azithromycin for sinusitis. Every upper respiratory infection, we did many times, we did audit. And in that audit, and nearly 90% of the antibiotic is not indicated. And many doctors giving azithromycin for sinusitis. Okay. Is it clear so far, Ejama? So we can now go to the key point, summarize what to do, general measures, self-care advice, fluid, paracetamol, ibuprofen, saline, nasal spray, saline for nasal spray. Here we are talking about respiratory tract infection, viral infection.
Vitamin C.
Saline, not Otrivine, not fluticasone, throat lozenges, stem cells, like symptomatic treatment. Yes, Doctor?
I see also we give vitamin C.
Yeah, yes. It's not a bad to give it, but it is also not not recommended in nice. Fluid paracetamol,
The main
nasal.
treatment will be, NSAIDs, morphine, or any kind of NSAIDs. That's the main.
Yes, because it is upper respiratory infection, is low grade fever, and some pain, discomfort, throat pain, nasal pain, paracetamol or ibuprofen. Okay, paracetamol or ibuprofen for fluid, saline, nasal spray, cyanomarine, whatever, and strip cells like that. Type, no antibiotic for virus, and most of it is viral. This is equal no antibiotic for upper respiratory tract infection unless there is exception. Okay, when to consider antibiotic? For the throat. When to consider antibiotic for the throat? when to consider antibiotic for the sinus. طبعا rhinitis in a common cold, of course, there is no. Antibiotic may be considered in exceptional case in the throat. Antibiotic may be considered in exceptional cases in the sinusitis. طيب when to consider antibiotic in the throat infection?
follicular tonsillitis.
Huh?
Follicular tonsillitis.
We will come to that if there is follicular tonsillitis, but we will go through the Centaur criteria, which is including what you are saying. Okay, bye. Centaur criteria 3 or more, or fever pain 4 or more. Fever 4, Centaur 3. Fever 4, Centaur 3. Here we can consider delayed antibiotic. And even Centaur criteria 3 or more, fever pain 4 or more, consider يعني syncope delayed antibiotic. يعني شنو consider؟ يعني still they give you the chance to give. طيب even that to give a delayed antibiotic يعني you give the patient a prescription. Okay, prescription that if he is not improving, then he can take. Right. Or if the patient is severely unwell or immunocompromised. Here in the throat infection, we can think of antibiotic. Delayed by Centaur or fever pain. Immediate if immunocompromised or severely unwell. The scenario will come like that. A patient 32 years old who is severely unwell, high-grade fever, very sick, they mentioned to you a lot of rooms of full housing of symptoms and signs of severity. Or immunocompromised patient, HIV, cancer taking anti-cancer medicine, renal transplantation taking immunosuppressive treatment, whatever. Like here, we can give immediate antibiotic. Now, this is either definitely he have bacterial infection, or he is most likely have bacterial infection, and if we delay the treatment, he can suffer severe consequences and complications. Same like when we are giving prednisolone to giant cell arteritis. Or rather, we are not sure there is giant cell arteritis, because there is the serious complication can develop if we delay. You got the point, Jama? It is immediate antibiotic in immunocompromised and severely unwell. Centaur fever pain, delayed antibiotic, not immediate. Yani give him a paper and tell him that after 2-3 days, if he is not responding, he can go to the pharmacy and take the medicine. Not starting today. Not immediate. Even with fever and Centaur. So this is a tricky point. If you read it like that, you will not concentrate here. There is word delayed. And many doctors, they are going directly to class antibiotic. No, it's delayed antibiotic. In immunocompromised, severely unwell, it is immediate antibiotic. And I am repeating why, because this is a very important point. Okay, you got it, Jama? Allah, you need to repeat. Hello.
For me, clear, Doctor. I don't know about the rest.
Okay. Finish the throat. Most viral. Simple treatment. Safety ratings. Delayed by Centaur. Immediate if immunocompromised. In a summary. Okay, نجي للساينس. We already talked about when to give the sinus. Most of the sinus are viral. 3 are viral. Unless the symptoms more than 10 days or worsening after initial improvement. Type, Is a patient came to you, the scenario, this patient is having nasal block, purulent nasal discharge, facial pain, mild facial pain, low-grade fever, and it's looked like a sinusitis. More than 10 days, delayed antibiotic. Okay. When to start immediate antibiotic? Immunocompromised, severely unwell. Type, which antibiotic for sinusitis? Phenoxymethyl penicillin, or if allergic to penicillin, scenario will come like that. Patient have sinusitis. Now for considering antibiotic, he is allergic to penicillin. يا جماعة مشو كتبوا شنو؟ Azithromycin. Doxycycline. طيب.
يا بص
Yes?
السنتور كريتيريا شنو
Yes. These are the central criteria. Absence of cough, 1 mark. History of fever, 1 mark. Tonsillar exudate, the one what she said by the doctor, exudative tonsils. Tonsillar exudate, follicles, pus, and tender anterior cervical lymph nodes. Any one of these will get 1 mark. So if you have 3 out of 4, we can consider shino. Yes, doctor. If the scenario told you that patient 23 years old, he have a fever and tonsils, throat pain. On examination, there is tonsillar exudate. He have no cough, no shortness of breath. Okay, and there is no lymphadenopathy. How much is the Centaur criteria?
3.
3.
Mm.
So here we will consider delayed antibiotic. Okay. Bye. WHO, same same, nice. No, for laryngitis, no antibiotic at all. For sinusitis, delayed antibiotic if. For throat pain, delayed antibiotic if centor more than 3. Here we will suspect streptococcal. ولأنه streptococcal عشان كده شنو we are giving it what which antibiotic. يعني even if we suspect bacterial tonsillitis or pharyngitis, we are giving phenoxymethyl or doxycycline. Why? Because mostly it is streptococcal, which poorly responding to snow azithromycin. You got the point now? Okay, what are the red flag? Red flag means we consider snow
Mission.
consider serious or referral. Persistent high-grade fever more than 35, 38.5, difficulty swallowing, shortness of breath, stridor, if we suspect epiglottitis, very orbital swelling as a complication of sinusitis. The same question came last exam. You remember that case? We touched it in the recall. You remember this question, periorbital cellulitis? It came in the last exam. Recall.
Sorry, Dr. Sabmani. Regarding the pregnancy and children and doxycycline, any alternative?
Yes. If the patient is allergic to penicillin and at the same time pregnant or pediatric, what are the antibiotics?
For pregnant, we go for erythromycin.
Yes, very good. Excellent. For pediatric? Where we cannot give doxycycline.
Fluoxetine.
Penicillin and kefaloxin. Like if it is not severe, we can give kefaloxin. Like if severe allergy, يعني anaphylaxis, angioedema, urticaria. For pregnancy, we can give clarithromycin. Here is the only exception we can give azithromycin. Okay. So look at the allergy. If the penicillin severe penicillin allergy, anaphylaxis like that, we cannot give kefaloxin. Okay. I want you to show you the question which came the last exam in this topic. Where is it?
Orbital cellulitis, it's usually picture.
It came as a question online. Very orbital cellulitis. Anyhow, you will find it in the report. Not waste the time. طيب. These are in general the indication for immediate antibiotic. قلنا patient immunocompromised or severely unwell. طيب. Other indication for immediate antibiotic, otitis media, younger than 2 years. The question came on November 25. And again came the last exam. Okay. Type children with otorrhea who have acute otitis media. Also, this came the exam before the I think November 24. Patient with acute sore throat, pharyngitis, or acute tonsillitis, when the Centaur criteria more 3 or more, or that delayed antibiotic. Systemically unwell, immediate antibiotic. Symptoms suggestive of serious illness or complication, like mastoiditis, peritonsillar abscess, peritonsillar cellulitis, intraorbital or intracranial complications. High-risk patient. A lot of comorbidities, renal failure, lung failure, liver failure, neuromuscular disease, cannot cough, immunosuppression, cystic fibrosis, young children born premature, they have weak immunity. Elderly people have weak immunity, especially if there is hospitalization in the last year, type 1, type 2 diabetes, history of congestive heart failure, and use of glucocorticoid. Type, if we start antibiotic, for how long? Otitis media, 4 days antibiotic. Throat, 1 week antibiotic. Duration of respiratory tract infection, sorry. The duration, otitis media will take 4 days. This is the natural course of viral infection. Otitis media, we are expecting it to clear 4 days. Pharyngitis, tonsillitis, 1 week. Sinusitis, 10 days. Common cold, 10 days. The bronchitis, 3 weeks. This is a natural course. Still, we can wait for the whole period if there is no other indication for antibiotics. Right. هنا alternative if severe penicillin allergy. Type tonsillitis, we can give phenoxymiside, clarithromycin, erythromycin, if severe penicillin allergy. Otitis media, amoxicillin, clarithromycin. Pharyngitis طبعا no need. Any question يا جماعة؟
For how long?
صوت no.
For how long antibiotic?
For which one? for the duration of antibiotic for upper respiratory tract infection if indicated. طيب for tonsillitis أو for throat يعني for throat infection. قلنا ال 4 days دي يا جماعه الكورس اوف الناتشرال كورس. otitis media natural course. sore throat this is not type for antibiotic. إذا كان اخترنا if we choose the phenoxymethyl penicillin, the phenoxymethyl penicillin 5 days, phenoxy 5, clarithromycin 5, erythromycin 5. Why I am saying this? لأنه in the past it was 10 days for the penicillin. لكن the new guideline in the primary care 5 days antibiotic. Okay. Okay كده. Any other question? Okay. هنخلي النيومونيا شوية، هنمشي البرونكايتس ونجي راجعين للنيومونيا. طيب قلنا acute bronchitis still self-limiting. Yes, it can take 3 weeks. لو ملاحظين يا جماعة the acute bronchitis, the patient usually revisit and revisit and revisit and revisit. This doctor gave him a good treatment, and maybe he missed to tell him that this disease is viral and it will take long time. لأنه the viral go deep. The virus go deep in the airways. It will take long time to clear. Especially إذا كان شنو smoker أو dehydrated أو عنده a lot of any mucosal issue. It will take long time to clear from lower down. نتذكر كده يا جماعة. Just remember it like that. If it is in the ear canal is very short, صح? 4 days will clear. If it is in the throat, it will take a little longer duration. 7 days. If it's in the sinus is a little deep, يا جماعة, صح? And there is pockets here and there. It will take more than 1 week, 10 days. If in the bronchi, very deep inside the chest. It will take longer to clear. Simple, يا جماعة. طيب, we need to tell the patient. Right. It will take like about 3 weeks or as long as 3 weeks. Still, it is viral infection. Very few causes. What are the viral infections that can cause the viruses that can cause acute bronchitis? Influenza, parainfluenza, rhinovirus, RSV, corona. What are the bacterial causes? Mycoplasma, chlamydia. This is, but then if antibiotic is indicated, this is something else, not like the throat, not like the sinuses. Throat and sinuses, if bacterial infection is a cause, it will be streptococcal. That is why we'll give phenoxymethyl penicillin or doxycycline. The other medication only in exception, or if we have no choice, then we can give azithro, clarithrol, and others. The bronchitis. Bronchitis is mycoplasma, chlamydia. The symptoms, everybody knows. Dry cough. Sometimes may be productive. Noisy chest, noisy cough. The sputum may be mucus. If it is a really viral, mucus white, sometimes rusty. Rusty, I'm sure many of you got rusty mucus, especially in these days, in the last few months. Not necessarily bacteria. So the color is not enough. Since it is a bronchi, and the bronchitis same like COPD, asthma, it will cause some wheeze. So this is infectious wheezing. Low-grade fever. Usually, patients will have a preceding symptoms of upper respiratory tract from which the infection going down. So he have upper respiratory tract for 2-3 days, and then he develop productive cough. So upper respiratory tract, there is no cough. If the patient develop cough after that, no, it is going down. In the X-rays, there is no consolidation. In the examination, there is no crackles. Usually, it will take 2 weeks, up to 3 weeks maximum to clear. Red flag, if it is there, we need to consider alternative diagnosis. If there is shortness of breath at rest, tachypnea, hypoxia, focal chest signs like crackles, hemoptysis, or if the patient is elderly or immunocompromised or heart failure. What are the routine investigation for acute bronchitis? No need. It's clinical diagnosis. The X-ray is only in exceptional cases. So in acute bronchitis, we are doing so much X-rays useless, and without any justification, just to satisfy the patient. Am I right, Jama? You are doing that or not? You know it is bronchitis. There is no any focal.
I'm not doing, to be honest, but as you said, literally, most of my colleagues, they do so for the satisfaction of the patient, but it's baseless.
Yes, sometimes even they are not seeing the X-ray. They just do it. or they are just opening it and closing. So if there is no dyspnea at rest, hypoxia, crackles, hemoptysis, immunocompromised patient, heart failure, elderly patient, there is no, if they ask you what is the next step, it is a clinical diagnosis. Unless you suspect pneumonia, unless the cough is more than 3 weeks, unless there is these features. If suspected pertussis, there's whooping cough, then PCR. All right, how to treat bronchitis? Now, this lecture is very important for exam, for practice. Okay, if you practice in any country where there is strict guidelines, they will love on you. Okay. Reassurance, and always tell the patient, explain the nature of the course. Tell him clearly. And you can even draw a paper and draw the bronchi and tell him this is viral infection is going deep. It will take like 2 weeks to clear. No need to take antibiotic unless you develop any one of these red flags. You can come back, we can think of it. Otherwise, don't go to the pharmacy or to other doctors to give you antibiotic. All right. Antibiotic, not routine. When to consider delayed antibiotic if the CRB is between 20 and 100. Here, delayed antibiotic. We know it is bronchitis, like in CRB is high, delayed antibiotic. This is equal to the Centone criteria in the throat. Okay, and equal sinusitis more than 10 days. Bronchitis with CRB 20 to 100, delayed antibiotic. When to give immediate antibiotic? Equal immunocompromised, severely unwell in the throat and the sinus. When to give immediate antibiotic in bronchitis? Yes, elderly, immunocompromised, respiratory distress, very unwell, CRB more than 100. Highly expected. أول ما جابوا questions منها. Highly expected question in this part. Okay. What are the bronchodilator? Yes, you can give if there is wheeze or bronchospasm. It will help. What are the differential diagnoses? Pneumonia, asthma, COPD, viral cough, or post-viral cough. What is the post-viral cough, ya shabab? The virus clear, but there is cough. There is post-viral cough and cough variant asthma. Anyone will give me the description, the key features to differentiate between the two?
البوست فايرال كف بيكون ما عنده أي other symptoms، لكن bronchitis بيكون معاه other symptoms.
اوكي ثاني.
هو الدكتور من الهيستوري نفسها البوست فايرال، يعني كان في عندنا فايرال انفكشن
صار عندنا
تمام.
فيروس.
after the viral infection the cough starts and might take something like 3 weeks.
My question is that number one, the comparison between bronchitis and post-viral cough.
ما هو الهيستوري.
Yes, bronchitis, there is this feature يا جماعة. There is dry cough, sputum production with fever. Okay. طيب post-viral cough, there is only cough. Virus clear. No fever, no mucus production. It is dry cough. Post-viral cough, there is a history of virus. Maybe in the bronchitis also there will be history of virus. So it is not a key feature. And post-viral cough is a dry cough. No fever. And there might be some wheezing in there. Okay? And it may be night cough more. Right? This is a post-viral cough. Bronchitis, there will be fever, productive cough, patient will be a little bit sick, and so on. Type. The second comparison between post-viral cough and cough variant asthma. Doctor? What are the key features to differentiate between post-viral cough? Now we know. There is viral respiratory tract infection, after which there is dry cough. Okay? No, nothing else. طيب الكف variant asthma. The cough variant asthma also triggered by upper respiratory tract infection. Like other than upper respiratory tract infection, it can be triggered by exercise, it can be by cold air, allergens. So it is asthma with cough rather than asthma with wheezing. No wheeze. يعني شنو؟ There is behavior of asthma in a term of allergies triggered by exercise, by cold weather, by respiratory tract infection. And it is dry cough. But everything of asthma, but there is no wheeze. There is only cough. Okay. They may be mild shortness of breath. Otherwise, there will be night cough, same like asthma. Exercise-induced cough, same like asthma. Pheno, what about the pheno? In cough variant asthma. May be elevated. لأنه قلنا هي the behavior of asthma. طيب. What about the post bronchodilatory? Well, there is no wheeze, لكن is there any improvement after bronchodilators? Yes. The cough will go after bronchodilator or after ICS. لأنه فيها الأخلاق بتاعت الأزمة. There is allergies, there is eosinophils. The only thing is that it is asthma without wheeze. The cough variant asthma is an asthma variant without wheeze. with cough only. That is why it is cough variant asthma. التعريف النهائي أزمة صح؟ It is an asthma with cough only. No wheeze. خلاص, everything of asthma is there. Even the treatment. Clear يا جماعة؟ Because the treatment is totally different. The post-viral cough treatment, we don't need to give anything. Just reassurance, hydration, avoid smoking. We tell the patient, just wait, it will go alone. In the cough variant asthma, the treatment, we can do investigation to confirm, same like investigation. Spirometry, pheno, spirometry, BDR, peak expiratory flow. To confirm the diagnosis, because it is a sort of asthma, it is a variant of asthma. What is the treatment? Same like treatment of asthma. Air, Marty, and lab. Okay, جماعة, clear؟ ولا نعيدها تاني؟ يلا يا شباب. You will go to the website. There is a very tough questions in this part. We'll do it alone. Okay. نرجع لموضوعنا. bronchitis. Antibiotic. There is delayed antibiotic and there is immediate antibiotic. Delayed by CRB only. Immediate, extreme of age, immunocompromised, comorbidities, CRB more than 100. Antibiotic, doxycycline. Alternatively, amoxicillin. Why doxycycline? Because it is mycoplasma. If it is bacterial, mycoplasma chlamydia. Why we didn't select azithromycin or clarithromycin here? Resistance. طيب. That is acute bronchitis. نجي like chronic bronchitis, COPD. We'll take 5-minute break. طيب, before to go يا جماعة. والله, in order to get the high benefit from the lectures and from our discussion, it is very important to read the note before the question, before the lecture. يا جماعة, you have a good chance. والله, all the previous courses, they don't have it. Now you have the note in the website. You have a lot of questions. I want you to come to the lectures for discussion, for high-level discussion. Okay? You have the highest chance to do it fast and to get the benefit for a high-level discussions rather than just teaching. Okay? You need to read the note before the lecture. to answer some question before the lectures. Did some challenges. Make challenge for yourself and answer question. Okay? We will do it in the next lecture. Before the lectures, just go and read the note and answer some questions. Come to the lectures that you understand everything. You want only few points to concentrate on it. If you face some difficulties in the questions, you want some part of the note is not clear, so we can discuss it. Agree يا جماعة معي؟
أيوة والله فعلا هي أفيد والله.
يس يا بوس.
جربنا والله كذا مرة في الكورس اللي فات. الواحد لما يجي للمحاضرة قاري لو ما أخد فكرة بيكون أفضل oriented أكتر.
Yes. حاجات معينة to fill the gaps. يعني he have some topics in his mind he want to know, to learn, to discuss. A lot of questions, يعني especially the difficult types of questions he passed through in the question bank. Okay, he will come. There is some point he didn't understand. It is difficult to understand. Wasting his time, he leave it to the lecture. So, يعني rather than to discuss all the topic. طيب COPD. The name tells us, this is chronic. طيب, when to say this is chronic? More than 3 months for the consecutive 2 years. A cough of 3 months in the 2 years. 3 months in the last year, 3 months in the year before. So 3 months or more for the last 2 years. So this is a chronic. Obstructive means there is obstruction. The FEV1 over FVC is less than 0.7. So this is a chronic obstructive pulmonary disease. It is obstructive picture with symptoms and signs and spirometry. And it is chronic more than 3 months for the last 2 years. More than 3 months barrier for last 2 years. Okay? Right. This is a chronic bronchitis. The other form of COPD is emphysema, where there is destruction of the alveoli. Type. What are the causes? The acute bronchitis, the causes are mostly viral, less bacterial. What is the causes of chronic? The causes smoking or biomass fuel exposure, occupational exposure, or genetic, like alpha-1 antitrypsin deficiencies. We will expect genetic if there is COPD in young, or COPD in non-smoker. If there is no smoking or occupational, and there is COPD here, we will expect genetic like alpha-1 antitrypsin deficiency. And the age will be more than 40. And if you remember, when we did the lecture of the asthma, we said we need to consider alternative if the patient came with asthma symptoms above 40. Here we will suspect COPD rather than asthma. what is the key feature to differentiate between COPD and asthma? Chronicity and irreversibility. We said asthma is an inflammatory, reversible, variable. In COPD, it is chronic, it is progressive, it is destructive, it is obstructive, it is irreversible. Okay. Feature, chronic cough, usually with productive of a sputum, and feature of obstruction, shortness of breath, wheezing, and there is frequent exacerbations, especially in winter. And there is complications of the chronic obstruction. Complication will be on the right heart, like right heart failure, core pulmonary stenosis, burial chest. Okay. Fine. How to diagnose COPD? Symptoms and signs, spirometry, because we need to know the obstruction. In order to diagnose the obstruction, here there is no FeNO, there is no BDR, BEF. Here, symptoms and signs and the spirometry is enough. Symptoms and signs, and there is spirometry feature of obstruction. FEV1 over FVC is less than 7, 0.7, is confirmed. It is not suggest. It is not support. It is confirmed the diagnosis. So the diagnosis is confirmed. Clear, Jama? So easy. Okay. When to do X-ray? If you want to exclude the emphysema, to see if there is any lung polyp or patient cancer have symptoms, we need to exclusion cancers. We need to do a CBC to see if there is any polycythemia as a secondary to obstruction, sputum culture, and if of COPD in young, what is the next test in terms of diagnostic test? Alpha-1 antitrypsin level. Same like asthma, with a little variation in number. Severity by FEV1. In asthma, طبعا 75, above 75 is normal. In COPD, the normal will accept it above 80. So above 80, why above 80 mild, ya jamaa? We didn't say normal. Why there is no normal here? ملاحظين حاجة؟ Even above 80, we say normal. Maybe 90 is normal. Above 80 mild. Yani we didn't say normal. Why? حتى لو 100% ممكن نقول mild COPD. That means this FEV1 will diagnose, confirm the diagnosis if below 70. Like if the patient have symptoms, he have these symptoms. If he have these symptoms, the FEV1 will be for the severity. If we diagnose it clinically, and there is COPD clinically, the FEV1 will be for the classification rather than confirming the diagnosis. And we can say the patient is 85 FEV1, 85 from predicted. Anyone who noticed a difference, Jama? Why we say here less than 70? Here we say more than 80 is mild. Here only less than 70 is diagnostic. واحد يكون لسه ما نحسان يا جماعة عشان نديه يعفي من باقي الريسبيراتوري. يا شباب.
معلش دكتور سؤال مرة ثانية.
Why we are saying here FEV1 over FVC less than 70 confirms the diagnosis. وهنا we said FEV1 more than 80% still, even if it is above 80, it is still COPD. طيب يا جماعة. For diagnosis, we are using the ratio. تذكروا when we said asthma, COPD, bronchiectasis, all of them, the ratio less than 0.7. The ratio will confirm the diagnosis of obstruction. It will not differentiate between asthma or COPD or bronchiectasis. It will just tell you there is obstruction. The post-bronchodilator, FEV1 or FVC, it's confirming every. But in the patient, in the context of symptoms of COPD, and there is obstruction, it is obstructive. Symptoms of chronic bronchitis with ratio less than 0.7, this is not just a bronchitis. This is chronic obstructive pulmonary disease. Yeah, you know. عشان كده كلكم سكتوا. يا جماعة ratio to understand it, what is the ratio? The force vital capacity is the whole volume which you can exhale after a full inhalation. And patient بياخد deep breath and he exhale all the air, maybe 4 liters. Full exhalation, maybe over 10 seconds. Full exhalation. This is a force vital capacity. All the amount of air the patient can force it out after full inhalation. We will ask the patient to take a deep breath, full in, then full out. This is the whole amount of air. This is a force vital capacity. What is the force expiratory volume in 1 second? This is the first second, the air which come out in the first second. طيب اصلا الاكسبيريشن الاير اللي بيطلع في الثانيه الاولى, this should be most of the air that come out of the lung. The force expiratory volume in 1 second should be near the force vital capacity if the lung is intact, if the bronchi is intact. فإذا كان الفورس expiratory volume in 1 second far less than the force vital capacity, that means there is obstruction. يعني البيشنت مفترض يطلع الهواء في الثانيه الاولى دي, معظم الهواء اللي بيطلع في الفورس فايتال كاباسيتي في الاكسليشن كله مفترض يطلع في الثانيه الاولى اذا كان اللنج اوكي. طيب if الثانيه الاولى الهواء اللي بيطلع قليل معناها فيه obstruction. اذا كانت القله هذه وصلت مرحله 0.7 او 7 من 10 فديس is obstruction. اذا البيشنت عنده اخلاق بتاعت ازمه, this is ازمه. اذا عنده اخلاق بتاعت bronchitis, this is COPD. This is confirming انه COPD. طيب انتهينا من التشخيص. دايرين نشوف السيفيريتي. السيفيريتي بتاعت الازمه بالاف اي في 1 الون, مش الاماونت من البريدكتد نورمال, مش divided by force vital capacity, لا, اف اي في 1 على الاف اي في 1 النورمال. again هنا الريشيو اف اي في 1 على الاف في سي. صحيح كده يا جماعه؟ طيب هنا predicted normal FEV1 force expiratory volume in 1 second في هذه اللحظة على الفورس expiratory volume in 1 second اللي مفترض تكون نورمال. البرديكتد نورمال. طيب كم البرديكتد نورمال لمستر اكس؟ سي انه 4 لتر. طيب كم الفورس اكسبيراتوري فوليوم اللي قدر يطلعها الان في الديفايس؟ احنا متوقعين انه يطلع لنا 4 لتر على حسب طوله وعمره ووزنه 6 بتاعته. طلع 3 معناها الفورس اكسبيراتوري فوليوم البرديكت from the predicted normal, the percentage of force expiratory volume, it is 3 out of 4, it is like 75%. طيب what is the benefit of this? To diagnose. What is the benefit of this? To classify mild, moderate, severe, and very severe, لأنه this will diagnose and this will predict that kind of treatment. Will help you to decide which treatment you will do. عشان كده in the exam, concentrate what you want. What the scenario, what is wrote in the it is the ratio from the force vital capacity or the FEV1 of the predicted normal. طيب ال FEV1 if the patient is the ratio is less than 7 he is COPD خلاص diagnosed COPD. ب force vital over FVC. طيب لكن نفس البيشنت ده the FEV1 على البردكتد ال FEV1 حقته الآن في الكلينيك divided by the predicted normal 90%. Still he is COPD like in mild. 50 to 7 to 80 moderate. 30 to 50 severe. Less than 30 very severe. This is opposite to asthma. الأزمة كم يا جماعة؟ الأزمة الكلاسيفيكيشن بتاعها عشان نعرف نفصل بيناتهم. أزمة طيب ها
75.
أزمة more than 75 mild 50
50
to
to 70,
75
moderate,
55 moderate
below the 50,
33 to 50 severe less than 33 life threatening. اوكي يعني ال FEV1 على ال predicted normal it will not help to diagnose, only will help to classify. The diagnosis is by the ratio from the force vital capacity. The severity is classified by the predicted normal. The FEV1 divided by the predicted normal. يعني the percentage of the FEV1 from the predicted. عشان كده even if it is 100 still the diagnosis is there. Okay. So how to confirm? The question can come like that. The patient is having feature of chronic bronchitis. How to confirm? بتعملوا confirmation بشنو؟ بده ولا بده؟ بالريشيو ولا بالبردكتد؟
الريشيو يا وص.
diagnose بالريشيو. طيب البردكتد الفايدة بتاعته فقط في شنو؟
severity.
Classification of severity. البيك اكسبيراتوري فلو ما بنشتغل بيه في السي او بي دي. It is underestimated. طيب how to treat COPD? Non-pharmacological, smoking, vaccination, pulmonary rehabilitation, nutritional, oxygen if oxygen tension less than 7.3 kilopascal or there is cold pulmonary. طيب what are the treatment for chronic bronchitis? For relief, acute, short-acting beta agonist, salbutamol or SAMA. طيب next step. If the symptoms is still there, then we will see هل في أخلاق بتاعت أزمة في البيشن ده؟ إذا في أخلاق بتاعت أزمة بنضيف ICS and long acting beta agonist. زي كأنه أضفنا له اير أو مارتي. يعني patient came with COPD. What is the treatment? Short acting beta agonist. First step. SABA or SAMA? Not responding. Next step, check if there is any atopy, variability, reversibility, eosinophils. If there is any means انه ده COPD لكن بشنو مركب مكنه بتاعت شنو؟ بتاعت ازمه. عنده اخلاق بتاعت ازمه. طيب ده بيستفيد من الاي سي اس. ندي اي سي اس، لكن الاي سي اس دايما ما بندي لوحده. ندي معه لونج اكتنج بيتا اجونست. حيكون شغال بسابا بلس long acting beta agonist and ICS for formoterol and budesonide. واذا ما في ريسبونس بعد ذاك ممكن نديه تو لونج مع الاي سي اس. طيب من البدايه اذا ما في اخلاق بتاعت ازمه نواصل له بالسابا ونضيف له تو لونج. اوكي exacerbations in the acute exacerbation الكلام اللي فوق ده كان مينتيننس. طيب اكيد حيجي كل شهرين ثلاثه حيجينا باكساسربيشن. طيب في الاكساسربيشن نواصل بنفس الميديكيشن دي ثابته كما هي، لكن بنضيف لها ريليفرز برونكو دايليتر باي نيبيولايزر اور سبيسر اورال شورت كورس كورتيكوستيرويد for 5 days 30 ملغ. for asthma how much يا جماعه؟
40.
40. for genital arthritis how much is it?
50.
60. طيب antibiotic إذا كان في feature بتاعت bacterial infection virulent high grade fever severely ill we can add antibiotic. This is the management of acute exacerbations. طيب قلنا الأكسجين only if you can less than 92 and the target will be 88 to 92. We will increase the target only if there is core pulmonale. Use Venturi mask. Check ABG every 1 hour. Already the patient شغال في ongoing medication. We can, during exacerbations, Ventolin, Atrovent, back to back, same like asthma, acute exacerbation. If not responding or developed feature of severity, non-invasive ventilation. طيب what antibiotic? Doxycycline. For 4 days. Oh, 5 days, sorry. Because there is a start dose and then 4 days. Or amoxicillin for 5 days. طيب feature of severity non-invasive ventilation اللي هو باي باب. باي باب يا جماعة باي ليفل بريشر، ندفع الهواء دفع بهاي بريشر ونقلل البريشر اراوند الماسك مع الاكسبيريشن عشان نخلي الهواء يطلع. اوكي. The in pressure will be 12 to 15. The out the expiration time يكون الضغط 4 ل 5. كده بيخلي الهواء يطلع. ندفع دفع ونخفف الضغط around الماسك وقت الاكسبيريشن عشان الهواء يطلع بروح. hospital admission criteria. إذا كان في comorbidity, failure of treatment, frequent exacerbation, or always oxygen saturation is not going above 88, like that. Okay. Any question? طيب نجي للانديكيشن اوف اوكسجين يا جماعه، لونج تيرم اوكسجين ثيرابي. اول حاجه لازم البيشنت شنو؟ اهم شيء شنو؟ الشرط الاساسي عشان to give the patient to think of oxygen.
Stop smoking.
Stop smoking. طيب long term oxygen therapy is more than 15 hours per day at home لpatient with stable COPD لكن عنده chronic hypoxia. طيب what is the problem of chronic hypoxia? What is the complication of chronic hypoxia اللي بتخلينا نفكر في long term oxygen therapy شنو؟
البرين. أيوة.
Not the brain. The complication will not be on the brain. Complication will be on the heart. Pulmonary hypertension, right heart failure, core pulmonale. Okay. The chronic hypoxia will affect the heart. لأنه chronic hypoxia will induce pulmonary artery pressure, cause pulmonary hypertension. Right heart is weak, cannot pump against a high pressure in the pulmonary artery. So will develop right heart failure, peripheral edema, pulmonary hypertension, and at the same times, there is a big problem with a chronic hypoxia. Chronic hypoxia living in a high altitude, smoking, COPD, what he will develop? Secondary polycythemia, hematocrit more than 55. So secondary polycythemia, it can induce coagulations, a lot of other complications. Type. If the patient is having COPD with chronic hypoxia, our target is to prevent these complications. To give the oxygen if there is any feature of these complications. Or the oxygen is low, there is hypoxia, so these complications are impending. or definitely coming if we didn't intervene. What are these predictors? COPD plus oxygen saturation in the venous blood, the arterial blood gas, less than 7.3 kilopascal at rest. Associated with polycythemia or core pulmonary or cyanosis. Here alone, this is enough indication for LTOT. Because there is hypoxia. And there is starting polycythemia, starting core pulmonary and cyanosis. Class, what we are waiting for? Give the patient oxygen to break this cycle. If the hypoxia is there but mild hypoxia, how much mild hypoxia? Less than 7.3 to 8. Even if there is 7.3 to 8, lakin with this 7.3 to 8, there is more serious side effect. Not only polycythemia, not only cyanosis, not only core pulmonary. La, there is pulmonary hypertension already developed. There is heart failure, if there is heart failure already developed. Okay? Or there is polycythemia, but severe polycythemia. So, in summary, what are the indications for LTOT? Severe hypoxia with mild or starting symptoms of complications. Polycythemia, mild core pulmonary, mild polycythemia, cyanosis. Or if the oxygen is slightly reduced, but there is serious side effect. Pulmonary hypertension, peripheral edema, severe polycythemia. Type. The third indication, طبعا any one of these, not necessarily the three, يعني. Anyone. The third is nocturnal desaturation or exercise-induced desaturation. Alone is considered for LTOT. Clear يا جماعة? Indication of LTOT, the three indications. لأنه أي indications من ديل is combination of indication, not only one. يعني severe hypoxia مع secondary polycythemia و cyanosis أو core pulmonary. Nocturnal desaturation, he will develop more hypoxia at night. كيف؟ يعني if he is having normal, for example, if he have a normal oxygen saturation on daytime, لكن there is drop at night time, that is nocturnal desaturation. Or he have a normal oxygen at rest. As exercise, it will reduce, the oxygen reduce. ده معناه إنه شنو؟ الريسيرف تعبان جدا، ما في أي احتياطي. شخرة سايب تعمل لها هيبوكسيا. لو لعب حبة لعبة رياضة بسيطة تعمل لها هيبوكسيا. ده معناه قاعد.
هل في دروب معين بيجيب يعني مثلا 10%؟
No, not necessarily. Yes, any reduction, any desaturation.
يعني
ما هو how much is the definition of saturation? بتين نقول البيشنت desaturation if it is the oxygen below the normal. How much is the normal? How much is the normal oxygen?
For patient has booked ولا normal?
I mean يعني how much is the normal oxygen saturation? Below it is a desaturation. How much is the normal oxygen saturation?
90.
For the normal person, 98.
اكو ده اذا كان نورمال بيشر يعني هو up to 94 some guidelines 95. This is normal. 95 to 100 or 94 to 100. 94 to 100. That is normal. طيب mild hypoxia 92 to 94. Severe hypoxia below 92. طيب what is the cutoff point for nocturnal desaturation? In the COPD. That is for the normal. طيب في COPD
58 less than 58.
في COPD قيسوا بشنو؟ إذا قسناه during sleep less than 90% during sleep nocturnal desaturation. خلينا نكتبها لكم. In COPD less than 90%. Less than 90% during sleep. For significant period. يعني for long minutes or hours. كويس؟ Or drop of 3 to 4% from the daytime level. كده كلير؟ اوكي يا جماعه. كده وضحت يا دكتوره؟
Yes.
Okay, يبقى before L-TOT we need to check the the ABG for after 6 weeks of clinical stability. We need to check it during patient clinically stable. بتين to check الأوكسال ABG عشان نحدد ال L-TOT. لازم we need to check the oxygen by ABG and the patient is stable for more than 6 weeks now. So we need the real oxygen during a healthy period. We are not checking the oxygen saturation during the exacerbation. Of course, it will come low. So we need the oxygen saturation during no exacerbation period. During a healthy period. Okay? Chest X-ray and echo same. CBC to detect the polycythemia وبلس oximetry. طيب هل حنشتغل بالاكسجين ساتوريشن لما نجي نقرر الالتوت؟ حنشتغل بالبرسنتج ده؟ ما بنشتغل به الا في النكتورنال ديساتوريشن، لانه ده بالبلس اوكسيمتري بالفينجر وما ريليبل ما اكيوريت. الاكيوريت بالكيلو باسكال ده بالكيلو باسكال او بالام ام ميركوري ده بتاع الاي بي جي بتاع الارتيريال بلاد جاز. البرسنتج ده بتاع الكابيلاري بتاع الترياج العادي في العيادات ده. البلس اوكسيمتري is screening, is not a diagnostic. The diagnostic والالتوت decider is the ABG. What are the contraindication? Smoking. If there is no hypoxia, if the patient is non-compliant, how there is psychiatric illness.
بيكون بالنيزل العادية
شنو؟
at home.
A long-term oxygen therapy?
أيوة.
It is here. How will be delivered? طيب. هو there is L-tooth if there is chronic hypoxia, ambulatory oxygen if there is desaturation on exertion, short burst oxygen, this is if for the severe breathlessness, palliative oxygen for relief in the terminal patient. Right. How L-tooth will be given? Anyone have patient with L-tooth? Or so a patient with L-tooth? شفت patient يا جماعة؟
أنا مرة شفت واحدة من الريلاتيفز، لكن
يلا
صراحة ما حضرتها وهي، لا ما حضرتها وهي، لكن زي حقيبة صغيرة كده شايلها، لكن ما حضرتها وهي بتستخدمها.
كيف؟ how in the face? How in the face? It is mask or nasal cannula?
Nasal cannula.
هي طبعا عبارة عن أكسجين كونسنتريتر، يعني في الغالب أكسجين كونسنتريتر. طيب بيعمل كونسنتريشن من الأكسجين من الهواء العادي، بيكون كونسنتريتر أكسجين باي نيزل كانيولا. لأنه محتاجين not a high flow، محتاجين low flow 1 liter. Sometimes 1 liter is enough. بس مش بالفنتوري ماسك او بالنون ريبريذر ماسك بندي up to 15 لتر، صح؟ في الامرجنسي سيتويشن. هنا 1 لتر only، maximum 3 liters per minute by nasal cannula. طيب البرونكيكتسيس عبارة عن same like البرونكايتس، لكن there is pocket، there is destruction in the wall. شوفوا الأزمة reversible، الأكيوت برونكايتس عبارة عن inflammation في الوول. الكرونيك برونكايتس chronic inflammation lead to scarring irreversible obstruction. البرونكيكتس there is destruction in the wall and bucketing of the bronchi. It is more after infection, pertussis, tuberculosis, pneumonia, cystic fibrosis, immune deficiency, ABABA, ciliary dyskinesia or cartilage, autoimmune. Whatever the cause, features big clue, copious amount of purulent sputum, more with change in the position, more in the morning. There might be breathlessness with hemoptysis and clubbing. And there is crackles which completely change with cough. Crackles لكن significantly change with cough. يعني تخط السماعة تسمع كراكل، تقول للبيشن كح، ترجع السماعة في نفس المحل ما تسمع ايش. الكراكلز اختفت مع الكح. فديس is A crackles that is not relieve, that significantly relieve with cough. This is pointing towards bronchiectasis. اوكي. اذا كان السي او بي دي بنشخصها بالاف اي في 1 على اف في سي، الاكيوت برونكايتس ما محتاجه حاجه. البرونكيكتسس سي تي سكان وهاي ريسوليوشن سي تي سكان، لانه عايزين نشوف we need to see the tram track appearance. We need to see the wall of the bronchi. In order to see the wall of the bronchi, the gold standard, we can do X-ray, لكن the gold standard is شنو؟ CT scan to see the tram track appearance. This is a normal section of the bronchi, cannot be seen, but in the middle there is one section, there is tram track appearance. This is شنو؟ bronchiectasis. Treatment, rehabilitation, vaccination, antibiotic, doxycycline or amoxicillin, nebulizer, long-term macrolides. خاصة إذا كان البيشنت عنده long-term exacerbation, we can give long-term antibiotic. Any question? Okay. We have only few minutes for the pneumonia, but it's not high yield. Pneumonia, we have acute community acquired pneumonia, and we have atypical pneumonia. Community acquired, which we can get it from the community. What are the causes? Streptococcus pneumoniae, cytalism, H. influenzae, Moraxella catarrhalis. Atypical Mycoplasma legionella, chlamydia. Hospital acquired staph, aspiration, Klebsiella, Staph aureus. طيب. Investigation, symptoms and signs. Cough is dry cough usually لأنها شنو يا جماعة؟ Interstitial. ما فيها production. Bronchi is clear. Bronchioles clear. Alveoli is clear. The infection is here in the interstitial. Lately, it will affect the alveoli. So the air in the bronchi is normal. It is interstitial infection. عشان كده in the X-ray you will see consolidation, بطش، لكن الهواء intact. There is air bronchogram. There is air in the bronchi. That means the bronchi is normal. There is air inside the bronchi. But there is consolidation. There is pus, white, potash in this lung zone. This is the air bronchogram. That is why it is dry cough يا جماعة. Pneumonia is a dry cough. ما في ميوكس. الميوكس ده بتاع البرونكاي، bronchitis. Pneumonia is a dry cough. Lately will be productive. طيب severity. إذا كان السيفيريتي بتاع السي او بي دي بالاف اي في 1 على out of predicted. هنا بالكيرب. الكيرب عندنا 2 كيرب. remember يا جماعة. برايمري كيرب بتاع العيادة وكيرب بتاع المستشفى. The curve of the primary care is a CRB. There is no urea. There is CRB only, not CURB. طيب بتاع المستشفى فيه يوريا. But same. Important to know that the duration of symptoms in pneumonia. Fever 1 week. Production of the sputum 4 weeks. Shortness of breath will take 6 weeks. Fatigue will take 3 months. Overall, to become back to normal needs 6 months after pneumonia. طيب atypical pneumonia. There is atypical presentation. There is maybe severe consolidation. Like patient is walking, talking, smiling, playing. This is a walking pneumonia. The X-ray is bad. The patient is look normal. And there is extrapulmonary manifestations. Like in mycoplasma, anemia with a Coombs test positive. تاني شنو؟ Skin rash. In the Legionella, sodium is low. And a patient is coming from hotels or whatever. Okay, you can read the remaining of the note. There is a lot of details, but these are the important points which usually come in the exam. Any question? Antibiotic, first line, coamoxiclav or ceftriaxone metronidazole or levofloxacin metronidazole. ما بيسألوا من antibiotic لأنه there is different local guidelines.